This video is to talk about the pathogenesis of infective endocarditis when caused by bacteria. This is Megan May speaking, and this is for our osteopathic medical knowledge course at University of New England, though if it is helpful to others, I hope you're enjoying. Right, so this short video is going to talk about types of bacterial endocarditis and then just go through the pathophysiology of acute and subacute endocarditis. All right, I want to start by talking about the clinical presentations of infective endocarditis, or IE, is how you often hear it referred to. The basic commonalities of this clinical presentation are fever, systemic symptoms such as kind of a flu-like presentation. People are obviously febrile, but they're achy, they're tired, they're just have general, I really don't feel well. The severity of those systemic symptoms is going to vary greatly depending on whether we're dealing with acute or subacute endocarditis, but we'll get to that in a second. The other big feature that you see in over 85% of patients is a novel onset heart murmur. So these are murmurs in patients who did not previously have them or have minimal history of cardiac problems. There's an exception in there, we'll get to it in a moment. The other big thing that you see are emboli. And depending on where those emboli land, then you can also see clinical presentations that include things like delirium if they wind up in the brain, chest pain if they wind up in the lungs, etc., etc. So those are the big commonalities. Now to get into acute versus subacute, here's what you would expect to see, clinically speaking. For acute IE, you're going to have a very sudden onset. This is an incredibly severe clinical presentation, and it develops and escalates quite quickly. So this is where you're going to see a much higher fever. You do see the systemic symptoms, but typically speaking, the entirety of the clinical presentation is so severe and so hyperacute that you don't really think about them. A patient with acute endocarditis is not really going to be complaining about being achy and tired. They obviously have other problems. Some of the earliest presentations of IE in patients who aren't previously hospitalized, we'll get to who those are in a moment, can include somebody coming into the ER with stroke symptoms or pulmonary embolism symptoms that are concurrent with fever. When you see that happening, you definitely want to think about infective endocarditis, particularly if they have other certain risk factors. Hold that thought, we'll get back to it in a second. Subacute endocarditis, on the other hand, completely different. This is a very long-term development where a patient is feeling unwell for a period of weeks to a few months even. They'll have low-grade fever and kind of general yuckiness going on. They're achy, they're tired. If somebody comes in and says, geez, I feel like I've had the flu for ages and I can't seem to get rid of it and something's going on, I don't quite feel right, but there's no specific symptom, in certain patient populations, this might be something to put on the differential. Once again, get back to who those patient populations are in a second. Alrighty. To delve a little deeper into acute versus subacute endocarditis, as you might guess, these are associated with different organisms. Acute endocarditis is associated with some extraordinarily severe bacterial pathogens. The biggest offenders here are Staph aureus and Strep pyogenes. If you're looking at a clinical time course to decide, is this patient acute or subacute, you obviously want to look at the duration of symptoms in addition to the severity. So for acute endocarditis, you might have a patient come into the ER at the kind of end stages of disease, or you can have a patient come in with a high fever something acute is clearly going on, or a patient in the ICU starts developing a high fever, and by the time you sort out, yes, they've got acute endocarditis, they're really on a very fast downward spiral. On the other hand, the subacute, as mentioned on the previous slide, is going to take weeks to months to get to that point. So your patient populations for acute endocarditis are as follows. The first guys that you're going to be paying attention to are the ICU patients, particularly if they have indwelling devices. One of the things we'll see in a second when we talk about the pathophys of this illness is that a key feature is introduction of bacteria into the bloodstream. That can happen by one of several ways, but one of those ways is by an indwelling device. And so your ICU patients who suddenly spike a high fever, particularly if they've got a pacemaker or something like that, this is somebody you want to be paying particular attention to. The other big patient population that you want to think about, and these guys are usually the ones who show up in the ER, are intravenous drug users. If you have patients that are either sharing needles or reusing needles or preparing their injectables on a non-sterile surface, there's a high potential that they're going to inject themselves with some kind of infectious agent. And if that has a tropism for the heart, as Aureus and Pyogenes would, then it's entirely probable that you'll see an acute endocarditis develop. The final patient group that you would see as being high suspicion for acute endocarditis are patients who've recently had a very severe staph or strep infection in some part of their body that is prone to greater invasion. So that would be something like a septic arthritis patient or a patient with a deep dermal infection. If you have staph or streps that are very, very good at tissue destruction, that are internally causing an infection and have access to a capillary bed, it's entirely probable they can invade the bloodstream and cause acute endocarditis, if not overt sepsis. This is one of the reasons why, in OMK listeners, you may remember this from week 4. This is one of the reasons why we talk about it being critically important to consider hospitalizing septic arthritis patients, to keep them on IV antibiotics. The reason for that is you don't want that condition to escalate. If it escalates into sepsis or acute endocarditis, that's obviously associated with a much worse chance of fatal outcome. Subacute endocarditis. So on the other hand, if you have to have endocarditis, this is the one you want. This is going to be caused by what are normally considered fairly innocuous organisms. So Enterococcus is the most common cause, different Enterococcus species. Some other alpha hemolytic strep species, there are numerous ones that fall in this category. Their taxonomy is a little bit in flux, so we just want to remember alpha hemolytic streps. And in addition to that, there's a whole wide variety of oral cavity commensal microbes that in certain patients you can see showing up as causative agents of subacute endocarditis. One phrase to watch out for is the following. This phrase right here. Viridans. So a lot of people describe this group of organisms as the viridans group Streptococci. This is not a word with any taxonomic standing. It is not a species, even though a lot of books or board review materials refer to Streptococcus viridans. That is not really a thing, but it is a word that you see a lot because despite massive efforts by microbiologists and prokaryotic taxonomists, we cannot seem to dislodge this word from anybody's memory. So when you see viridans, it's referring to alpha hemolytic streps, and it is always going to cause this flavor of endocarditis. So, despite my disgust with the use of this word, I wanted to make sure you have all heard it, because as physicians it will come up in your life, unfortunately, even though it is, as I mentioned, not really a thing. Okay. So the time course for development of subacute endocarditis is weeks to months. So this is, again, a patient who's going to be dragging around for a while and, maybe have a low-grade fever, but mostly have an influenza-like illness type of feeling. The patient populations you want to watch out for here are as follows. These are patients who have underlying heart valve defects. So anything that's going to cause backflow of blood between valves. If you have small numbers of bacteria in the bloodstream, if you think about this kind of from a kinetic standpoint for a moment, if they go flying through the heart and don't have the opportunity to stop and attach to the heart valve, even though they're there, they're not going to cause you any problem. If you have a patient who's got any kind of regurgitation between heart valves, the blood doesn't just fly through their heart and move on. It flies through, gets spit back, goes through again, maybe gets spit back again. So those organisms in the bloodstream have a much greater chance to actually grab onto the tissue, attach, and start an infection. So you're going to want to look for patients with underlying valve defects. They're at higher risk for subacute endocarditis. The other big patient population that you want to watch out for are patients with missing teeth or any kind of dental issues where they're going to have repeated teeth pulls or repeated introduction of oral cavity organisms into the bloodstream. This is also why, though this is not a recommendation that's universally followed anymore, but this is also why patients who had valve defects were often given a short course of high dose of antibiotics prior to having dental procedures done. The thought being you wouldn't want to introduce oral cavity organisms into the bloodstream in these patients that you know are at such higher risk. All right, so the process of infective endocarditis almost always, again, starts with bacteremia. So technical definition of bacteremia is any instance of having bacteria in the bloodstream. 99.9999999 bajillion% of the time, bacteremia is subclinical. We are all in a mild state of bacteremia each time we brush our teeth every day. That does not mean we are going to get sepsis or endocarditis. I also want to make sure that we're very clear that a patient does not have to be in the throes of what we would call clinical sepsis in order to be bacteremic. So make sure that you're very clear on the difference between those two terms. Sepsis is where you have a patient who is actively clinically sick. They have fever, they have systemic infection. Bacteremia simply means there are bacterial cells in their blood, and most of the time, no one will have any idea that that is the case. Okay, so now we're clear on that. We have some bacteria in the bloodstream, and they got there however they got there. Think back to those previous two slides, right? They might have been injected in the course of drug use. They might have jumped off from an indwelling device. They might have come through a hole or a breach in the oral cavity. However they got there, they're now there. They pass through the heart, and if they're able to adhere to the surface of a heart valve, then you have the start of the process of infective endocarditis happening. This is where things break apart into acute versus subacute, right? So this is in both, this is in both. If you have toxigenic bacteria, like a staph or a strep pyogenes, that are capable of making a certain type of toxin that we'll get to in a second, you are likely going to wind up with an acute endocarditis. The effect of the toxin is going to give you an acute inflammatory response, see why in a second, which is going to lead to massive necrotic cell death. When you have massive necrotic cell death, you are going to have when you have massive necrotic cell death in a critical vital organ like a heart, you are going to have a rapidly escalating acute situation that has a high mortality rate. That's what you see with acute endocarditis. Subacute, and I apologize, I'm not sure what happened to my font over here, but subacute, where you have insidious bacteria that are adhering to a valve that are not capable of producing these particular types of toxin, again, you'll see that on the next slide, they're going to lead to a chronic inflammatory response. So obviously it starts as acute, but it's a low-level acute response. And then you wind up with this transitioning into chronic inflammation. You see formation of fibrosis, and you see the formation of what are called vegetations in the heart. So these are coagulated bits of fibrotic tissue, dead bacteria, old bacterial biofilms, basically just crusted onto the surface of the heart valve. I'm not clear if you chatted about biofilms with Dr. Good, but in case not, just as a reminder, these are complex microbial communities. They're often polymicrobial, although in the case of infective endocarditis, they're usually just made of one organism because it's typically a pretty sterile body site. This is where you have bacteria on a surface, and they sit down on the surface. They start secreting out polysaccharides. They build this nice protective shell around themselves, and this makes them particularly difficult to treat and get rid of. It protects them from both antibiotics and also your immune response. So between the formation of these biofilms and the formation of fibrosis, you really wind up with quite a lot of crud, for lack of a better term, all over the surface of the heart valve. But because this is not an acute situation, the clinical presentation is also fairly insidious, right? So this is just a chronic inflammatory response. So no, the patient doesn't feel well, but they're not dropping dead either. Okay, so as we've talked about this a little bit already, but just to reiterate, the establishment of bacteremia can come from multiple places, and then IV drug use is a big one. So again, that's reuse of needles, sharing of needles, but also the preparation of the injectable is where a lot of this is going to come from. Dental extraction is huge. Anytime you pull a tooth out, that's obviously a fairly bloody medieval process. And if you have a lot of these organisms living in your oral cavity as a habit, and in particular if you have a heart valve that's prone to regurgitation, this is a high-risk procedure for you. And then the other big thing is having indwelling devices, particularly pacemakers. So these were the methods that we talked about. This, again, somehow my font got a little messy here, but this said various catheters and scopes. This kind of falls in this category over here. And, sorry, I don't know why I did that. Depending on the source of the bacteremia, that's going to give you a higher probability toward acute versus subacute endocarditis. Again, dental extraction, you're not typically going to see an introduction of Staph aureus or strep pyogenes. You have a high probability of seeing a bacteremic introduction of alpha hemolytic streps or Anarococcus or any number of oral cavity commensals. So this would tell you dental extraction is almost always associated with subacute endocarditis. On the other hand, IV drug use falls in the other category. So if you are injecting through the surface of the skin where Staph aureus lives very happily and of course doesn't really bother you, if you then share that needle with another person or reuse it on yourself, you've taken something that's probably now contaminated with staph bacteria and re-injected it into the bloodstream. So in that regard, IV drug use is going to be more likely to be associated with acute endocarditis. So think about how the bacteremia is being established and think about which type of organism is going to come into the bloodstream by that method of induction. That'll give you a hint as to whether that method is associated with development of acute versus subacute endocarditis. Finally, the other thing we talked about was this invasion of the heart valves by distal infections. So we talked about septic arthritis. I didn't mention it, but another big one is puerperal fever. So those are almost always going to give you acute endocarditis. These are usually caused by staphs or streps. So to talk about the mechanisms of acute endocarditis and how this presentation develops, we need to talk a little bit about a couple of toxins. The first that I want you to know and be familiar with is something called the PVL toxin or Panton-Valentine leukocidin toxin. That's made by Staph aureus. The other is a toxin called streptolysin, which is made by strep pyogenes. There are a whole bunch of others, but the thing that I want you to be familiar with is how they work. And despite differences in shape, despite differences of how specifically the toxin attaches to the host cell, there's one key feature that they all have in common that I want you to be familiar with, and that is that they are pore-forming toxins. Okay, so whether toxin molecules bind onto a receptor on the host cell, chuck that away, and then multimerize to form a channel where things can go in and out indiscriminately, or if they bind directly to the membrane, cause it to kind of collapse in on itself and create a channel where, again, things can go out or in indiscriminately. The key to the formation of this lesion is the hole in the cell membrane. All right, so think to yourself for a second. If this is the membrane of a cardiac myocyte, right, and it is suddenly poked full of holes, what is going to happen to it? Pause the video, think to yourself, what would happen to a membrane full of holes? Okay, I'm assuming you paused. And we didn't have one of those awkward things like we do in class where then I have to like giggle and smirk at you until someone says something. Or I call on the table that's sitting right in front of me because I can hear you whispering it. Anyways, the point being, what is going to happen is that all the stuff that's inside is going to go flying outside, and eventually, if that happens to enough molecules, you are going to have this massive osmotic disturbance, and the entire cell is going to blow up, right? So you can see why, from the pathophys standpoint, it doesn't really matter if it's binding a receptor or the membrane. The key trick here is that stuff can flow from the outside to the inside of the cell indiscriminately, and that is going to cause the cell to blow up. What kind of cell death is that? Think about it for a sec. Hopefully you've come up with an answer. And we'll go over here. So starting with PVL toxin, again, you could substitute in here streptolysin or any other pore-forming toxin. made by an agent of endocarditis. But starting with PVL tox, you're going to have necrotic cell death, right? Hopefully we all recognize that was not apoptotic cell death. That was just described. Dr. Colley would be very sad if that were the case. That is going to give you an acute inflammatory response. I think, again, my font is goofy here, but an acute inflammatory response is what we're after. All right, so what happens during an acute inflammatory response caused by a bacterial agent? So you have an infiltration of neutrophils, right? And they try really hard to clean things up, but they have a whole bunch of staph bacteria. They have cell debris to deal with. There's a whole bunch of everything, and then they start degranulating like crazy. And when neutrophils degranulate, remember what happens? Is that pleasant for all the surrounding tissue? It is not pleasant for all the surrounding tissue. All the surrounding tissue ends up similarly dying necrotic cell deaths, and then this just snowballs unto itself until you wind up with this big, big, big giant lesion that gets bigger and bigger and bigger, and the situation gets more and more acute. And that is why, as you could imagine, the heart winds up looking like this. And also, as you can imagine, there's a reason why this particular heart is being imaged in a cross-section on someone's pathology table, right? Because this is a very acute presentation with a respectively high mortality rate. All right, on the other hand, let's think for a moment about the mechanisms of acute endocarditis, right? So you start here with bacterial adherence. Technically, you start with bacterial adherence with acute as well, but we, for the sake of interest, skip right to the part where they start secreting toxin and blowing holes in the cell. That being said, that's not going to happen here. You're just going to have bacteria adhering onto the heart valve. And it's going to cause inflammation, but it's not going to cause the just dramatic inflammatory response that we see with acute inflammation, because it's not as though you have danger signals and dead cells all over the place in addition to these very, very hygienic organisms being present. You just have a small number of bacteria present that are stuck on the heart valve, not really bothering all that much. So you get an inflammatory response, and it starts as acute, and then it transitions to chronic, right? And as that happens, so here you go, you transition to chronic. As that happens, you start to see attempts by the body to resolve that inflammation. So you see a lot of, fibrin formation. You see a lot of attempts at healing, and you see ongoing inflammatory responses. Right, so think about how that would just kind of drag on and on and on and on. And then think to yourself about the clinical presentation of that patient. They have a chronic inflammatory response going on in a an extremely vital organ. And so that is going to give them, obviously, a clinical presentation. So I don't want to minimize it. But it's not that same dramatic presentation that you get with acute endocarditis. Because yes, you've got some destruction of tissue. Yes, you've got inflammation, but you haven't got that just rapidly escalating lesion that you see in acute. That being said, this isn't minor. This can be fatal. And what you can see here is that you have development of these vegetative lesions where you have, again, this just collection of yuck on the heart valve. This is old dead tissue. This is attempts at coagulation. This is attempts at clearance of biofilm material that the organisms are making. And the nifty thing about this is you can actually see it on ultrasound. So if you've watched videos, and if you haven't yet, I'm sure you will, of cardiac ultrasounds, what happens is this valve right here will be a little line, and it just wiggles back and forth very quickly. And when it flips up like this, corresponding to the valve being open, during vegetative endocarditis, you can see that this is all kind of fuzzy and cruddy looking like that. This is where you run into problems with emboli as well. And you, again, actually see this with acute endocarditis as well, is that pieces of this yuck and pieces of this dead tissue can actually break off and go flying around to other tissues. And when that happens, when you have embolus formation, depending on where the emboli land, that's going to dictate what complications you have from your acute your either acute or subacute endocarditis. If they land in your brain, you're in trouble. If they land in your lungs, you can be in trouble. If they go around on their own and then your immune system either absorbs them or breaks them apart, you're in less trouble. So that is something we want to keep in mind as a definite complication of subacute endocarditis. Acute endocarditis has its own set of problems, right? Where you can have a patient die of the infection itself, in addition to dying of effects of an embolus. But for subacute, this is something that you absolutely want to aggressively treat. But the big complication here is this, rather than the infection itself. The infection itself is actually not super, super awful, but it's just this formation and the reduced function of the heart valve, and then the potential for this damaged tissue to break off that really causes the problem. All right, that's all I got for you guys. I hope you enjoyed. We are going to talk directly in class on Thursday, the something of October, 16th of October, about blood and cardiac infections, and so we'll retouch on infective endocarditis very briefly, but mostly we're going to talk about cardiac parasites and sepsis and all kinds of fabulous hemorrhagic fevers and viremias and all that good stuff. So I will see you in class then.